Hi, good afternoon, everyone. My name is Dr. Shannon Walker. I'm a postdoc here at CASE at the Swetland Center for Environmental Health, and I'm happy to serve as the moderator and catalyst for today's discussion. I just want to open the floor up for any conversation starters, prompts, or questions amongst the folks in the room. It's a pretty big room. Wow, 35 people.
I had a question. Darcy Friedman, also with the Swetland Center, the 3 phases of population health, social drivers. How much do you think people are aware that there are these 3 and like that we're trying to be in the 3rd bucket? And like, what does it take to get there? So I was curious to see what the group thinks about that.
Well, I know that I'm not supposed to answer all the questions, but maybe I'll prime the pump with this one. So interestingly, I don't think very much at all. I don't think there's a lot of awareness. And so one of the very first things that I worked on at the AMC, this is back in like 2012, was a partnership with Academy Health, which represents health services researchers. And so we looked at kind of all health services research that was focused on healthcare equity for like I forget the time frame, but it was like a 10 or 15 year period. And way back then at 2012, we had seemed to turn the corner from first to second generation. And most of the studies were really why these healthcare inequities exist. But then I'm reminded, like during COVID, right, what was one of the many kind of recurring themes is our lack of data, right? Our lack of demographic data, our lack of kind of the descriptive data that we need for first generation science. So I think the framework, we might not be too aware of it. I think there has been movement to really, among those of us doing the work, to stick to that 3rd generation. But I think our infrastructure is like pre-generation 1, right? We don't even have the stuff we need to do the right descriptive evidence.
I feel like something that comes to my mind as you were talking about those sort of 3 generations too is, you know, each individual researcher, research team, or even institution like might fall into one of those buckets predominantly. But if you look across the health services research field, for example, like we span that whole spectrum. And then there are a lot of people, as you said, like way upstream, like not even there yet. And we do need some of both. But I think about progress in terms of like, where is more the attention shifting? Like, are we getting more to solutions? But you can't really like jump all the way to solutions. Like there is an evolution for each person doing this work. Like you've got to understand what disparities are there and what health inequities exist. You've got to understand why. So there's like a homework portion. And I think it gets me thinking about just training. Like how do we build that in so that people aren't mid-career before they're ready to even begin thinking about solutions.
Yeah, to follow up on that, I teach in the health professions education classes, and we've introduced structural competency and we've given them exercises on it, and then more recently, we've even taken the case studies that we did in that class and turned them into systems thinking classes for the students. And we got a lot of pushback from the students, like, why do I need to know this? This isn't pertinent to my career. And, we as faculty are hitting ourselves on the head, like, why don't think this is relevant? I mean, so yeah, we're still stuck in the first bucket.
I wonder, have you seen that shift at all recently? I mean, I hate to say it, but like as more research funding is directed towards equity or, has an equity component, like I would think that would be a motivator, but maybe students are not, like maybe they're not yet feeling those sort of incentive structures.
It could be that. It could also be that, granted, this is a first year class. So first year, med students, first year nursing, first year dentist. We partly felt it was maturity, like they haven't lived enough and experienced enough to see the connection with what they're going to be doing in the future. It's just too early in their training. Maybe that's naive. I don't know.
Jeff, I see you have a hand up.
Yes, thank you. So I'm at University Hospitals, Connor Whole Health, and we do a lot of electronic health record research. So we have delivery of care. We've got 10 music therapists across 12 hospitals. So we use the electronic health record. And I will say, and I've come from a place, line of health, where we did the same kind of research for many years. And I will say our electronic health records do a horrible job of collecting good data on the variety of demographics that would be important for understanding the population for whom we serve on both ambulatory and inpatient settings. So it's a barrier to doing population health research because we really can't trust the HR data on languages or other types of things, education levels, even race or ethnicity. So I think that's one barrier towards moving this forward, is we can't even converse about this because we just don't trust the data as much as we should. So just to put that out there.
And the needs, right? The needs of data that the healthcare system has is the same need and want that public health, that housing, that transportation, that urban planning, right? So it's yes, it's about kind of the EMR and locally gathered data for issues of healthcare equity and certainly population health management. But then we need to connect those data, have those data talk with information from other sectors. When we're thinking about interventions, we're thinking about solutions that certainly extend beyond the walls of a hospital or a health system, right? We also need to have that exchange of ideas and information across sectors.
Absolutely.
So, part of our work is really trying to advocate for, what is the core set of information that really would allow a multi-sector, right, health equity agenda that solutions focus really thrive and help us evaluate our interventions, help us do some of that formative work. We're light years away.
Absolutely. And issues with food insecurity, transportation, that's not even, but it's a part of healthcare. I mean, if you have transportation issues, you can't get to your appointments, you look like a no-show, and in fact, you have a lot of challenges. And so, so I think it's some gaps we need to fill. And it looks like I saw in the quote or in the chat, it's not just EMR or EHR limited, but it is really a challenge. So I appreciate your conversation. Your 4x4 was great. Thank you.
So I had a question to pose to the group at large. Other than data limitations and issues with the EMR and other mechanisms like that, what are other challenges that present when we try to foster equitable research collaborations between institutions, and who are stakeholders that we can engage to sort of address those challenges?
I have a response to that. It was related to a question I wanted to pose as well. So I'm Daisha Wolf. I'm at the Oregon Health and Science University, the CTSA here, and I'm a KL2 scholar. So one of the things that I was impressed by your 4x4, Dr. Alberti, was your comment that stakeholder engagement is not engaging your stakeholder advisory board a couple times a year and having them do a parade for you based on your ideas. But I'm finding in my own training that's actually what we're being taught as training, is to build these boards for the projects that we have. And to your question, Dr. Walker, what I'm facing is we put together these boards, but there's no infrastructure to sustain them beyond the projects that we have funded for a specific period. And so that's something that I am, going around the university trying to find before I get these folks on board, because this is what's happening to me, is that we have really great investigators doing really great work, asking really great questions in the community. And then by the time the next investigator comes, those folks are gone, long gone, along with whatever progress that's been made to advance not only trust, because we just talk about trust all the time as if it's some blanket thing, you know, that once you have it, it's there. But in moving any of the work forward and being able to respond to the changing needs of whoever your partners are, all of that progress is lost as well. So for me, I'm thinking a lot about infrastructure. And then when you do have these boards or groups or partner collaboratives, how do you make meaningful use of your gathering? And, you know, if it doesn't have to be these large board meetings full of experts doing their expert thing, what else can we do meaningfully at different intervals throughout the project?
I have so many ideas, but I don't want to bogart the conversation. So I'm going to be quiet for some time and let other folks jump in. But so much truth and wisdom right there. All right, well then I'll jump in real quick. So you mentioned the word infrastructure, and I think that is absolutely key. And so it's the infrastructure, though, that allows for continuous integration and engagement of community in the absence of research grants, in the absence of experiential learning opportunities, right? In the absence of the program, right? So that infrastructure has to also translate into like incentives, right? For bread breaking, even when it's not tied to your R01 or to your class. So what is the organizational, we talk a lot about individual competency. What is the organizational competence to sustain community relationships that aren't kind of born on the backs of one or two or three people who might be, as you said, transitory? So I think that's a huge part of it. And then part and parcel, that kind of authenticity that derives from that investment in the kinds of infrastructure. And it's, yes, incentives and merit and promotion, but it's also like fiscal readiness. Right? How many times have you had to, work with community partners to fill out W-4s? Is that the most efficient thing in order to pay your experts as experts? Probably not. So the infrastructure is really is broadly defined. But for us in the center, the first thing that we focused on is kind of the fundamental infrastructure is like trustworthiness, right? And so what does it mean, again, at that organizational competence level? And I think, Shannon, to your question, what's a barrier, what's a great hindrance, is the lack of our organizations, of almost any organization, kind of actively in a hyper local, like meaningful way, demonstrate that they are worthy of community trust. So I'll be quiet and I'll drop a link into the chat that's kind of the product of a community partnered piece of work that we undertook to develop these kind of principles and toolkits around organizational and individual trustworthiness. But I think developing that infrastructure, making those investments is one way to begin to show the authenticity of that trustworthiness, and that we're in those relationships for the long haul and not just for the project.
I'd like to jump in. I work at UH and I'm not involved in research or anything like that. I work with the residents in radiology. But I think that idea of the ends and the means have to be congruent. So I think I guess like within the residency program, students are traveling through the program. And so their lifestyle and their mindset is project-based, but getting them to switch and understand that they're actually learning system-based approaches that they need to take everywhere with them, and that they can't just we can't graft ourselves onto things. Is a big takeaway I'm taking. So thank you. This is great conversation.
PJ, go ahead. Floor is all yours.
Thank you. Dishelle, I love your comments on your insights on long-term sustainability. I will admit before I share, I'm on my second week of a new position at Better Health Partnership in Cleveland, Ohio. But my perception and really why I joined is that we are really that neutral convener that's meant to sustain initiatives long term. So a lot of organizations pay to be a part of Better Health Partnership, and we facilitate that collaboration long term. I think it's a really promising model that I've seen. Obviously biased at this point, but I think it's a really promising model for not just healthcare systems, but community organizations and really any stakeholders involved in advancing health equity to be a part of that work. Admittedly, the work that I'm tagged to is a 5-year grant, and that is a question we don't have answered yet, is what happens after year 5, and we've evaluated it. But I think it's a really interesting question for us to ponder.
Delius, and then Allison.
Hello, good afternoon, everyone. My name is Delius Norman, and I'm a community outreach specialist and psychometric rater for SI Clinical Trials. We're a clinical researchers team in the Greater Cleveland region specializing in mental health. And I kind of wanted to raise the question of what's the importance of building bridges and relationships between clinical researchers and doctors, and what would be everyone's advice with, I guess, building those relationships and, I guess, a trust between the two.
I would say for me, one thing I think about in terms of partnership with clinicians, and I'm a social scientist, is in making sure that any sort of action steps or interventions I'm developing for change or transformation in the communities I'm serving actually makes sense, or that it's actually going to land in a place that where the uptake, makes sense if it's something that is designed to scale, that clinical sort of expertise is there. And I think for me, as someone who's new to the health fields, my social science is mostly been implemented in the education sector. I think the clinician input is important as I'm designing my research questions too, to make sure that I'm not just interested in these things as a social scientist, but that the questions I'm asking make sense for what patients are actually dealing with, what they're challenged with. And then also on the side of the clinician has no interest, in what I'm doing. Why would they utilize any of my findings to, to improve upon or to address, any kind of health equity or disparity issues that are going on with their particular patients and their.
Hi, I think I'll go now. I'm Allison Oraqua from the University of Southern California, CTSI in LA. This has been a great discussion. Thanks for holding this Un-meeting. I just wanted to talk about information infrastructure and how that, I think, is a very critical piece of the puzzle, and especially important during these, transitory project-based environment that we as researchers live in, and the importance of not only ending your 5-year grant or even 1-year grant in relationship with an academic publication, but translating it into community readable and accessible and searchable information. And we're actually playing around with ChatGPT to see if there are ways to just automatically generate some draft, summaries that folks might be able to learn from. So we're finding that so far it's pretty factually accurate, but I think we'll have a lot of different nuances depending on what the research is about. I also wanted to ask this group, is there a feeling that, we could make a repository of all these findings and interventions that seem to work and make them community accessible, but who is the audience there? Like, our community health centers, are other academic researchers interested in, instead of developing their own intervention, adopting an existing intervention that has been successful elsewhere and adapting it for their own locale? So are there repositories of interventions that are successful? Are they community accessible? And what's the feeling among academics about looking to those repositories to use them in their own work?
This is Mary Delansky. I'm just chiming in on a little point of clarification. Are you thinking like quality improvement projects, that we would take kind of the evidence that's already out there and just start implementing it in widespread sort of implementation that's non-funded usually, right?
Right, and it's also not always published and shared,
right.
measured and evaluated. So
There's
more
not
health services research, I think I'm talking about.
Yeah, so really like not academically incentivized to do. Right, but that would be cool to make a network across the country to do that. I think there are models of that at the, through the Institute for Healthcare Improvement, through collaboratives across the country. So maybe see what they're putting out through IHI. But I know in nursing, we have a whole degree of people, our doctorate of nursing practice, that's what their goal, that's what their projects are all on, our implementation of, kind of using quality improvement. So it's a great idea.
And even when there are examples of evidence-based interventions, right, the value of kind of co-adapting, if we're talking about health services research with patients, with administrators, right, to really develop and tweak the workflows, the evidence, the metrics that matter to your specific populations. I mean, I think no one's saying just pluck it out of here and stick it in over in a totally different context. I think that spirit of kind of patient-centered implementation science is certainly kind of central to healthcare equity research and policy, absolutely. And then the framing, my training as a social epidemiologist, my mentors kind of derived the social conditions like racism and classism as fundamental causes of disease. And they're fundamental causes because they control access to information as one of the kind of the key resources, right? So it's not just power and money and beneficial social connections, but Allison, you really hit on another important resource that is so crucial for population health and health equity, which is that information, right? And things like racism, classism, homophobia, the fact that we're not translating, our scholarship into stuff that's usable for different audiences, another way to control and reinforce those social factors that are causing kind of inequities within and across our community. So thank you for looking at that point.
Eugenia, I see your hand is raised. You're muted.
Hi, I'm Eugenia Sweet. How are you? I work with Metro as a research nurse, and I'm also a clinical instructor for nursing students. So I just wanted to mention a couple things. I can't remember who it was, but she was talking about how students don't seem very interested in these, talk about these topics. And I think what my experience is, has been that a lot of these new generations of students, it's almost like they are enclosed in their own world, right? They can't see beyond what's happening in their lives. So I one of the things that I really focus on, especially when I'm teaching in a facility like Metro Health, is for my students to understand who they are taking care of, not just focus on their skills, like, you know, giving medications or whatever. It's more like, what do you think is happening in this particular patient's life, right? Even if you have no idea, like if you've never been in that situation, just come up with some ideas of how we can help this person. Do they need social work? Do they need mental health support? Like, you know, so we come up, before we start the day and after we're done, we regroup and we talk about all these topics. And then the next time we meet for another clinicals, we talk about our experiences and how we can change and kind of like move forward with our new population of that day. So I think it really changed the view of the students, not just like it's something that they are making me learn. It's more like, let me think more outside the box and how I can actually help someone, even though I have never been in that situation. And as a research nurse at Metro, one of my experiences have been, because I'm an immigrant and I have an accent and I look different, I think a lot of the patients that we recruit, when they see me, they are like, oh, she actually cares about me because she represents me a little bit better than when other coworkers reach out to the same participants. I've had the experience where like they're like, I don't want that person to come, you come in here, let's talk about it. Let's talk about this research. And it has, I mean, I don't have a lot of experience compared to one of my coworkers, but it's just, I think it's just they see the reflection in me per se. So it's all of a sudden I started getting all these participants interested in my research just because of the way that I sounded and I look like, even though I didn't have a lot of experience. So I think we should, I don't know, it would be good to look inside our places and maybe look at who is representing us, right? Especially if you're working in a place where we have a lot of Spanish speaking people. Maybe we need to start hiring people that can talk to them in Spanish, or, you know, people, African-Americans, more African-American people, more, you know what I'm saying? I think that's something that maybe we should look into, just to, I don't know, to raise these questions. Thank you.
I do want to like say something about students, because I've been so interested to hear some of the impressions in this room. My experience kind of visiting medical schools and research programs is kind of the exact opposite. That this generation of learners, whether they're scientists to be or physicians to be, are way more plugged in to these issues and understand these kinds of connections between sectors, the roots of injustice and the roots of whether it's inequities in educational attainment or inequities in health status. And I think some of the limiting factors have been the faculty, right, the continuing professional education to actually instruct and cultivate this kind of almost like endemic understanding of kind of the vital conditions and structural forces at play at health. And then the other thought just slipped my mind, but I've had like the exact opposite experience. I find the limiting factor being the way that we teach and cultivate and not kind of the substrate. Oh, the last point I wanted to say is like, what are the 2 or 3, and this is a question for everybody, right? Not every scientist is going to be a health equity scientist. Not every physician is going to be a health equity advocate, and that's okay, right? But every one of us in the health field should have some basic core, whether it's structural competency or something, on these topics. So what are the 2 or 3 like core behaviors that every scientist, whether you're a bench scientist, a health services researcher, a community-based scientist, that every physician, whether you're a PCP or an orthopedic surgeon or a neurologist, like what are the 2 or 3 skills that all of these health professions need to have to kind of push population health and health equity forward, even if they're not going to be those self-selected champions, right? And then how do we operationalize and measure? Absolutely, humility, 100%. I love whoever typed that in, of course. So how do we test for humility, right? How do we demonstrate that skill in research settings? You know, the observable competencies in medical education. How do we watch an interaction between a resident and a physician and judge accurately humility? So I think we need to delineate those 3 or 4 kind of universal competencies and then figure out our measurement and evaluation scheme and make sure we have the faculty kind of able to teach those things and then show how they plug into this larger conversation of health and not just healthcare, or population health and not just population health management. It's all connected. And I think, so there are some other opportunities inclusive of students to think about how we push it forward more quickly.
I think one of those learning objectives could be that everyone who comes through our program needs to be able to articulate how their specialty has caused harm in communities, not so that we can guilt or shame, but just so that we can have an understanding. Like in radiology, we're hoping to bring a speaker who wrote a recent article about anti-Black discrimination specifically within radiology. And, you know, if you look at like OBGYN research, I think if everybody who leaves your program, they may not even agree with it because of where they're coming from, but if they can articulate some points of harm that their specialty has caused over time with the best of intentions, I think that could be one thing that we could measure.
You know, Margaret, I love that. The first principle of trustworthiness, and again, these were community developed principles. The very first one is the community is already educated. That's why it doesn't trust you, right? So I think it speaks to what you're saying, that responsibility, that acknowledgement of history, both, you know, history and currency or contemporaneous kind of abuses or neglects. So I think you're spot on.
So I would say, I don't know if this is a different scale, but it goes along with humility, is active listening. But like that's a thing that I felt like as I developed that skill, like it really transformed, like not just my work, but my career. Like I'm doing really different things as I gradually learn that. And so that's something we can teach. It's something we can, you know, you can actually observe that within conversation.
This is Mary. I just wanted to share, I wonder if in the curriculum that there would be some discussion about how the early learners, as they become professionals, can impact the community in some way. I think that's where they don't see the connection. I mean, in nursing, we train people to do a lot of tasks and the students really love those tasks. But they don't usually see the big picture. They see the individual, you know, delivery of care to a patient, but not to a community or a population. So it's somehow we can change their lens to that. I think that would be an important part of curricular change. And that's maybe the systems-based practice competency in medicine. And I know that we struggle with that competency a bit. And now we have that competency in nursing. So
And Mary, that was kind of our impetus for that pyramid, right? To locate, right? So you might be training in the health professions, but what skills are you teaching that then can be applied to socio-medical interventions or your advocacy, right? Or the way that you build partnerships. So we trying to lay out kind of a more comprehensive way so that what's happening at the top of the pyramid speaks to the actions that are maybe deeper in that population health impact.
Mm-hmm.
So Mary, I was just going to ask, I don't know if you're familiar with the collaborative practice class, but in that class, you know, they're learning how to work in teams because they're going to have to in medical teams. But those same teams are also doing a project with a community organization in Cleveland. And hopefully that they're picking up some of the things you just mentioned, that they're getting some of the evidence for that competency by doing that, by actually interacting with community organizations that are dealing with really wicked problems in the community.
Yeah, I'm in that class. I taught with you that systems-based practice one with Peter Hovman. And I just think they don't see it as part of their work. They see that as like, public health people, or they don't see it as part of their work if they're in a hospital working, or if they're in a clinic. Like, how are they ever they don't have time to even do the work they can do there. So why would they be learning about the community? They don't see that they can impact it unless you go into public health. I don't know. I think that's just kind of what I read from it. But
one of the things that I tell my students is you need to be the expert of each of the patient that you're seeing. And sometimes to become the expert, you need to learn about other things that happen around that patient's life. And part of that is going into the community and learning what are those things in the community that are happening, right? But you need to become the expert. And it's not just reading the notes in the chart or reading, you have to go further and deeper into each of those cases because each person is different. So I tell them, if someone comes in here, there is an emergency and something happens here, either here or outside the patient's life, outside the hospital in that patient's life, you need to be able, as a person in charge of that patient, you need to be able to be the expert and use your voice and express what's happening to this patient. So I think when you propose that to them that way, they start thinking, oh, wait, you're right? Because if whatever you're reading, you are not able to explain it to me, or whatever is happening in that person's life. Like when I tell my students, this patient is homeless. A lot of them like homeless. What? Okay, yeah, homeless. They don't have a home. No. You need to go and do a research, right? Do your own research. And next week, we're going to talk about homelessness and what that means. Not to you, but for the community, especially here in Cleveland. What does that mean? Because anyone can be homeless. It doesn't have to be someone that it could be you. So let's do some research about it and not just Google research. I want to see, that org research, right?
Yeah, and I love that. I think that's an excellent strategy. I'm gonna implement that. But I think for this class where we teach these 450 interprofessionals, I think that's the kind of thing we have to bring up front, like before we do the systems thinking exercise. Like, why is this important? How does this connect? So even if you're in a clinic or you're a physician in critical care, why is this relevant to your practice? And if we could maybe get you on video and tell this story, we would love to have you do. I'm going to come and video you.
Anytime.
Darcy?
It's making me think about like your comment of we teach people to do things and not really to be reflective and about what they're doing and how they're doing it might actually create an unintended consequence. And so, I think that's another opportunity. We just had a call today about a project, opioid fatality reduction, community teams, whatever, and all this stigma that just bubbles up constantly. And where is the space in a team where it's acceptable to reflect on the way that our biases and blind spots influence the work we're going to do? I mean, we all have that. What's the culture of collaboration that allows you to talk about that? Which means that for 10 minutes or whatever, an hour a week, we're actually reflecting and thinking. And there's no culture for that. And I think that's something to be integrating into our training. And it might make people we all are going to make mistakes. That's true. But we could also create spaces where we're maybe more attentive to that. And maybe we could not make that same mistake over and over again,
Thank you for that, Darcy. I do want to point out we do have just about 5 minutes left in the breakout rooms. So Daisha, and then any concluding thoughts. I don't want anyone to get cut off in the middle of a statement.
Thank you. And if anybody else wants to chime in, please do. I wanted to add something that we're sort of saying in the background, and it's effective communication across a variety of audiences. So again, with me being a trainee, you know, and in the program I'm in, I'm surrounded by a clinician. And as a social scientist, a lot of the, we miss each other a lot. And I sort of see, you know, they have these sort of one-off workshops where you can learn to communicate, you know, on an advocacy level, or you can learn to communicate, you know, with certain stakeholders, but they're sort of ancillary to the training experience, when it's super important, especially as students, and I'm in a Master of Clinical Research program, that from the beginning, if we're learning to do elevator pitches, what does that pitch look like to patients? What does that pitch look like to a community organization? What does that pitch look like to a funding agency? You know, what does that pitch, you know, look like to someone else that you're looking to partner? So I think my point is to have it more central to the curriculum and the objectives of the program, as opposed to being optional workshops or trainings that you could do as students.
Any last questions, thoughts, Dr. Alberti, anything on your end?
It went by so quickly. Thank you for the questions and your thought. I know I've jotted down 2 or 3 nuggets from you all that I'm going to take back and incorporate into our work. And just know that the Center for Health Justice is a willing and ready partner for anything you want to get going. We are really committed to kind of trying to help all institutions walk the talk on health justice. We really believe the process, and many of the pieces of the process we've talked about today are just as important as the product of the work. And so just thank you for all that you do every day, and looking forward to meeting more of you in the future.
And there is a call in the chat that we share email addresses so that we can build these collaborations and networks and connections out offline and outside of this unmeeting. So feel free to do that if you are so interested. And we don't have to wait for them to close out the room. If folks are ready to head back to the main room, we can just leave the room at the bottom of the screen and it'll take us back to the main group.